So what I'll really be talking about for thyroid is just the clinical aspects of our day-to-day practice and things we need to do, just focusing on some of the things which I feel as a clinician I incorporate to sort of try and achieve a diagnosis of thyroid eye disease when it overlaps with some of the other diseases. So 3 questions. Does the patient have thyroid eye disease? If it does, then do I really need to treat it and how do I manage it? So, does the patient have thyroid eye disease? The commonest presentation you get is unilateral lid retraction associated with thyroid eye disease in almost over 90% of patients. It can be bilateral or it can just be unilateral, associated with some soft tissue involvement, which can involve the upper lid, the lower lid, proptosis, lower lid retraction, and finally extraocular muscle restriction. Most of these, it can either be one or a combination of both, and that should always raise a suspicion. The most important thing is the feature of lateral flare, in which the lateral 1/3 of the eyelid is raised due to fibrosis of the fascia involving the LPS and the lacrimal gland, giving this characteristic appearance. Often the disease is asymmetrical. So it is written in books that it's very rare to have a unilateral disease, but I think in our population we do see a unilateral disease. Then, if the patient has it with the presentation, I also do take a little bit of history in detail. So here is a 28-year-old pilot who was not given a fitness to fly in spite of flying for a couple of years because he was told that he had thyroid eye disease. So he said, I've done it 3 times over the last year. I have new thyroid. So we went back and we said, let's do something simple as get a photographic documentation. So this is him about 3-4 years back. And that's him when he was a child. And though I also was trying to think that he could possibly have new thyroid, I realized that with no family history, that was just the way he appeared. And he also went ahead and got his mother's photographs which had similar appearance. So it's not always a patient with a presentation like this will have a thyroid disease. On the other hand, this lady came saying that she had recently got a proptosis with swelling. But when we took a photograph about a year and a half back, you can see she already has the eye disease which has started with the lateral flare and upper lid fullness. Then again, coming to biochemical investigations, the basic tests that everyone usually advises, and it also depends a lot on endocrinologists, is they either just do a TSH as a screening measure, or you can do a T3, T4. What I personally prefer to do is T3 with a free T4 and a TSH. And I now know the 5 or 6 endocrinologists I work with like what tests they want. So I usually go ahead and do something called a trap. But other than that, I just simply stick to these 3, which gives us the answer that we want. Now, trap in different labs have different meanings. So a lot of times the patients end up calling back saying that this is, what exactly do we mean? Do you want a TSI? Do you want a TTN? So it's actually just a combination of both these, which is what they test. So some labs call it trap, some have TSI as the name, though they are basically testing the entire range of hormones. This is just a general term. I do it because a lot of times the endocrinologists feel their treatment is based on this, though I don't think it really determines mine, but if they prefer it, I do it. So 70 to 80% of biochemical investigations turn out to be hyperthyroid, but there is an entity of 10 to 20%, and as we heard in the previous IC that there are a large number of patients who are euthyroid and will remain to be euthyroid, and sometimes they need to be treated irrespective of what the biochemical investigations are. Coming to imaging, and I agree with Dr. Ganga that we don't necessarily do imaging in every case. If there's significant proptosis, there's a sudden onset of diplopia, restriction of movements, obviously acute thyroid ophthalmopathy, or you're planning a surgical measure, then we go ahead with imaging. USG I don't do so much. In a lot of the endocrinologists have used to do it, send it to me, and I've encouraged them to not do it anymore. Yeah, if it looks something like this, which looks like an acute thyroid eye disease, and you want to rule out a dilated superior ophthalmic vein and acts as a screening measure. I am very pro CT scans, but not for every patient. Depending on the indication, you can pick up just early muscle fullness, straightening of optic nerve, or enlargement of muscles which causes a crowding at the optic orbital apex, for which you do fields and involvement of the lacrimal glands. MRI, I often find that other ophthalmologists who love doing MRI, and I always have a patient coming to me with an MRI because of, no, should we be doing a CT scan? But CT scan is still my modality of choice. So if now we think that, okay, the patient does have thyroid eye disease, do we really need to treat it? So you need to identify the phase of the disease. And this is a concept that we spoke about, where in the early 80s, the natural history of thyroid was sort of charted out, and Rundle said that there are two phases, an acute phase and an inactive phase. And he basically made this graph which said the acute phase lasted for anywhere from a year to 2 years, and the inactive phase followed that. In this phase, this is where the inflammation acts the most, in the active phase, and which can respond to treatment. Whereas in the inactive phase, you're dealing with a stage where the inflammation is no longer there, and usually intervention and treatment does not really have much effect. So what is disease severity then? Severity is the amount of deficit that is left in terms of squint, deviation, eyelid retraction. These are the functional deficits that's in the form of severity. This is the active and the inactive phase. Now when you want to classify this, Dr. Sampath spoke about the different classifications. So for some of you not here, I prefer to do something which was, came up in the 90s by Moritz and Kurni, called the clinical activity score, which basically has 5 points, 10 points, and 4 to 5 features which are divided. So the first 3 features, actually pain, redness, and swelling, give you a better idea of activity or the active phase, where the functional, the last 2 points actually give you a functional deficit. This study was done based on the response to immunosuppression. However, what they have found is, in a recent paper by Petros, they found that when they applied this clinical activity score and biochemical investigation and radiological investigation and put everything together, they thought this came the closest to really giving the severity and activity in terms of management of treatment, and is actually very straightforward to follow. So I always make it a point to mention and encourage the residents to write a clinical activity score after the examination of what they feel after they have gone, and we've actually put it up in the OPD so that they can just quickly do a run through it. The different classifications are there. I don't really use this. The ITIS classification, which was proposed by Whitman and Dolman, I like the fact, as previously said, it is a very time consuming, but what I like about this is the vision, inflammation, stress and appearance points. We have sort of summarized these points and made our own OPD sheet for examination, which doesn't really split hairs, but gives a better idea so that you don't miss out on any vision-threatening loss of thyroid eye disease. So how do I manage it? These are the basic management modalities. I'm just going to deal with this case-wise. So this is a 22-year-old girl who had all the systemic signs of hypothyroidism, but then also noticed she had this puffy eye swelling in the mornings, and suddenly her eyes were looking more prominent. She came after having gone to an endocrinologist, already diagnosed, and was on some treatment. So since she really didn't have any functional deficit and her activity was really less in terms of only just soft tissue swelling in the morning, we just put her on supportive treatment in the form of maybe raising your head when you're sleeping, giving tear lubricants, giving some tear lubricating gel in the night, and she was happy with that, and we really didn't do anything more, just observed her for any worsening. Coming to the second case, this lady came, again she was diagnosed, but she came with a little bit of restriction, proptosis, upper lid retraction, but more unilaterally. And in her case, I did later do a CT scan, because after about a 3-month visit, I felt she had worsened actually. And in that, her clinical activity score was about 3 to 4. But what we did is, we decided, since she was worsening in terms of her lid retraction, subtle and the fullness, we decided to, with the supportive measure, to go to the next level, which is to take in the form of steroids, which we gave her in oral steroids. And currently she was on a medical management for hyperthyroidism, but she was not responding in terms of the thyroid ophthalmopathy or the thyroid eye disease. And just, of course, over 6 to 8 weeks is what I start. And as Dr. Manal said, even about the other things in specific condition, I am aggressive about steroids. I don't like to undertreat where the patient is 50 kilos and you're giving 30 milligrams, you give it 50 milligrams, you give it as per the body weight, give the supplementary calcium, and explain to the patient that there is going to be a Mushish-Goy syndrome, but it will get reversed. And just with the treatment of oral steroids, the lid retraction went, her upper lid swelling reduced, and she was doing much better. Then this is a lady who was actually almost towards the end of her active phase and had eyelid retraction, little bit of lag of thalamus. She didn't really mind. But then as over the year and a half that we followed her, and she didn't have to, she had a moderate eye disease, she started feeling discomfort about the eyelid retraction. So we decided, along with the supportive measure that we were giving her, to do a botulinum toxin injection for the leg retraction. I usually give about 2 to 2.5 units transconjunctivally, either in the paracentral mid area or laterally. In this case, we've re-repeated, and I don't have photographs for that. But the first injection took care of a central middle retraction, but I've repeated about 2 units laterally to bring down the lateral flare, because she now is feeling much more comfortable with the lid retraction having come down. This is a lady who came, 50-year-old lady who came with a mild active disease. She did have a little bit of restriction, no diplopia, little bit of upper lip fullness, lid retraction, but she was fine with supportive therapy. Then 6 months later on a follow-up, she suddenly started worsening. Increased upper lip fullness, soft tissue signs improved, congestion, restriction, lag of thalamus. So we decided to try the first line of treatment as oral steroids. In her case, I did do a CT scan, but there was really not much on the CT scan except an increase in the orbital fat. So just with an oral steroid and supportive therapy, she responded very well, and 6 months post, her active disease has been suppressed and she is maintaining well. So this is a 24-year-old male came with active disease, which was actually, didn't look to me to have a high clinical activity score, but when I started examining him, he was giving a little bit of restriction, and complaining of grittiness. But then we did the CT scan because of his proptosis and his restriction and lid lag. And the CT scan was much worse. The CT scan had all muscles bilaterally enlarged. There was little mild lacrimal gland fullness. So in this case, instead of giving it a trial of oral steroids, because he had soft tissue signs, he had lacrimal gland, he had extraocular muscles, battles, we decided to take it to the intravenous methylprednisolone pulse therapy, which is in the form of 500 to 1 milligram, which I was a loading dose over 3 days, and followed by either a bi-weekly or every 3 weeks pulse for 6 cycles. I don't usually do it every week, I keep it for every 2 weeks. So this is his after the first 3 days, the loading dose. And this is him now, about 9 months later, and he's sustained well. This is a lady who came with an acute thyroid ophthalmopathy, like we say. We gave her pulse intravenous therapy, she responded. After about 6 weeks, she again got acute thyroid eye disease. And we didn't know why she was not responding. She was non-diabetic, but because of the pulse therapy, she got diabetes, she got a host of other things such as pneumonia. So finally we had to admit her, because then her vision just suddenly started dropping and she would not respond to steroids. So we admitted her under low intravenous steroids. So when I initially given her, we were aggressive in 500 milligrams. QID for 3 days, she responded. After 6 weeks when she came back, we discussed with the pulmonologist, the endocrinologist and the immunologist, because everybody got involved, and we decided to hold off her steroids and just go in for orbital decompression and do an intranasal medial wall decompression. And following that, we had to put her on a mild dose of steroids of just 5 milligrams just after decompression, and she has sustained well. The only thing she's developed is a cataract in the left eye, because that has helped us, because otherwise she had severe diplopia. Coming to the end stage disease. So often you see patients with all the lid retraction, the lateral flare, finally want where you intervene with surgical management. So this lady was keen on getting a better cosmetic appearance, and she went and underwent a bilateral decompression. In one eye I had to do a 3-wall with fat, and the other eye I did a 2-wall, and with a upper lid and lower lid recession surgery. And in some cases you have patients who come, at least I've seen in our country, who come like this, who do not want anything. They're just happy with this. They have the squint, they have the severe upper lid retraction, and they just say they're happy to be left alone, and I do just that. I just leave them alone if they're not bothered functionally and they don't have any cosmetic complaints. So to just speak about a few facts when we are managing this, is that not necessarily while your endocrinologist is managing the thyroid hormones, your thyroid eye disease is going to get obliterated, but you do need to tell them, and the best analogy I give them is that when you take you may be in 4th gear of a car, but you're not going to stop the process. The car is still running, and that's what you need to treat and come back if you feel that there's anything worsening. Smoking, I don't have any targets for the patients, but I do encourage them very aggressively to get off the smoking, because it worsens the disease. and older individuals, as we know, have severe disease and the associations associated. Thank you so much.